Thanks very much, Sunil. So we've got a lot to cover. This is going to be a bit of a whistle-stop tour. Don't worry about writing anything down. All the facts or the references that you need are on these slides, and these will all be available to you afterwards. Okay, so sit back and actually listen, and then you'll get much more out of this. So what I'm going to cover today is to start with a little bit about the pathology of minimal change in FSGS and a little bit about nephrotic syndrome in general. We're then going to look at some case presentations and use those to start to think about what treatments are available and how we should choose what we give our patients. And then we'll see if we can come to some conclusions between us at the end for you to take away. So minimal change disease, it's so called because it looks normal on light microscopy, but clearly it's not normal, and you can see here on electron microscopy extensive foot process effacement due to the collapse of the podocytes, which then results in the torrential proteinuria that we associate with this. FSGS, this is a misnomer. FSGS is just a lesion on histology, but we persist in calling this disease FSGS, and really FSGS and minimal change are a spectrum of the same disease. And you can see here what you see on the histology, which is just this scar, this focal segmental sclerotic lesion in the kidney. But the real point about this is that this is not necessarily idiopathic FSGS, and what we're going to be talking about today is idiopathic FSGS, because those are the patients that are going to respond to our immunosuppression and our immunotherapy. If you just have a scar due to some other reason, then the immunotherapy is not going to work, and it's absolutely critical that we decide what our patients have, and I'll come back to this a bit later on. So what are the common causes of nephrotic syndrome in adults? Well, it depends where you live. So in a European population, membranous is the most common, with minimal change at 15%, FSGS about 12%. If you compare this then to Chicago, where there's a high African American population, then FSGS becomes the dominant lesion with less minimal change, with again significant membranous but less minimal change. So the proteinuria in nephrotic syndrome is glomerular in origin, and the podocyte is the major target of the injury. And you can have congenital nephrotic syndrome due to mutations in nephrin or podocin, or you can have acquired either due to autoantibodies to the podocyte antigens, which you get in membranous, in minimal change in FSGS, what we have is actually a systemic disorder where there is production of circulating factors which cause destruction of the podocyte cytoskeleton and proteinuria. And you can see here, these are normal podocytes sitting very happily on the glomerular basement membrane. And what happens in minimal change in FSGS, which is, I say, is really the spectrum of the same disease, is you get some dysregulation of the immune system, you get activation of T cells and B cells with production of circulating factors which cause collapse of the cytoskeleton. This renders the basement membrane leaky and the albumin pours through into the urinary space. So minimal change disease, most of these are primary, but we do need to think about secondary causes, in particular drugs such as non-steroidals, some neoplasms, particularly Hodgkin's lymphoma, infections, allergy, and it can occur secondary to other glomerular diseases. So don't forget these, but they're less important than in FSGS, where there are multiple causes of scarring which give a similar opinion, a similar picture to idiopathic FSGS, and I'm going to come back to this a little bit later on when we talk about treatment. So let's start with a case. It's always easier if we can relate it to someone that we think about. So this is a 19-year-old Polish girl working in a bar who presented with ankle and facial swelling. Nothing else in the past medical history. She was referred to the renal clinic with heavy proteinuria, and blood tests and urine tests confirmed that she's nephrotic, severely nephrotic with an albumin of 17, urine PCR of over 400, with a normal creatinine and an elevated cholesterol of 10.7. And a biopsy shows that she's got minimal change disease. So, a few questions for you. First of all, does she need treating? What would you treat her with and for how long? What are her chances of relapse? And what would you retreat her with? Don't know, do we want to do a vague straw poll at this point, see what people are thinking? Who would treat her? Probably most, not all. Okay. What would you treat her with? Who'd give her steroids? Okay. Who'd give her a CNI, calcineurin inhibitor, tacrolimus or... Okay. What about some oral cyclophosphamide? Okay. What about rituximab? Okay, clearly not a rich audience. Okay. How long are you going to treat her for? Who says a month? 2 months. Couple of hands there. 4 months. Few hands there. 6 months. Few hands longer. Probably not. And what are her chances of relapse? What do we think about that? 10%? 20%? 30? 40? 50? 60? We've got about even for everything from 20 to 60 so far. Okay, and we'll move on to retreatment, I think, once we've gone through a little bit of the evidence. Okay, so the first thing to talk about is nephrotic syndrome itself. It is not benign, all right? There seems to be this sort of myth that minimal change disease is a benign disease. People don't go into kidney failure. You know, it's irritating to have, but it's not a problem. This is just not true, okay? It's a life-threatening disease. People die of thromboembolism, and there is multiple morbidity of that. But the other significant problem is acute kidney injury, and particularly in older adults. And one of the sort of catches we often see is if older people present dialysis dependent, and it's only once they start to recover some function or start to pass urine that you suddenly realise that they're heavily proteinuric, and actually if you look on the biopsy, their ATN is due to minimal change disease. Okay? Infections are less of a problem nowadays, but this was the major cause of death in children until we had more effective therapies that we do today. So this needs treating. And this is just a study really just to point out this about AKI in adults with minimal change disease. This was a study from the States. And they looked at 95 patients who'd presented with minimal change disease. And of these 95, about a quarter had AKI. And not insignificant AKI, 4 of these patients were actually on dialysis for anything between 1 to 6 months. Okay? And so they're going to be left with CKD. This is not a benign disease. And just the characteristics of those patients with acute renal failure, they tend to be older, they tend to have a history of hypertension, and unsurprisingly, they have lower albumins and more severe proteinuria. What about thromboembolism? So we know that this is an important complication of nephrotic syndrome, and the incidence is anything between, quotes, anything between 80 and 35%. Just as a poll in the room, how many people here would give prophylactic anticoagulation to their nephrotic patients? Okay, let's just say ever. Okay. So probably about half. And actually, most of us do give prophylaxis, but there is very little evidence on which this is based, other than the fact that we know that if you don't, there is a significant risk of clots. There are no randomized controlled trials. There's a couple of series. This was one from France of about 30 patients in whom they gave Clexane, which seemed to be, heparin actually, because this was before Clexane, which seemed to be effective. And then there's this decision analysis that was published in KI a couple of years ago. But if you go actually and look at this, you have to put in all sorts of factors, and it tells you what your risk would be of actually getting thromboembolism. But then there's a huge sort of clinical disclaimer at the end of it that says this is based on absolutely no clinical evidence whatsoever. So not enormously helpful. So what do we actually do in practice? Well, this is what we do at the Hammersmith. We keep it simple. We know that there are 2 things that affect your likelihood of getting thromboembolism. One is how low your albumin is. The lower your albumin, the more likely you are to clot, and also the type of glomerular pathology causing the nephrotic syndrome. And membranous glomerulonephritis is the particular worry, but minimal change, IgA, all these other causes of nephrotic syndrome equally can cause thromboembolism. So what we do is if your albumin is less than 20, we start you off with some low molecular weight heparin or warfarin if you have some untreatable reason for your nephrotic syndrome. Once your albumin improves and becomes between 20 to 30, we switch you to aspirin. And once your albumin's over 30, then we stop this altogether. And this seems to be reasonably effective. This is some work from Nick Thomas, one of our registrars, who looked at 143 patients that we'd treated over 5 years. And in those patients, there were just 2 blood clots, both in the first week from presentation, and it really wasn't clear whether those clots had predated the start of the anticoagulation or not. And also, it seemed to be reasonably safe. There were 2 patients, I think, who had emergency admissions for hemorrhage. So, relatively safe, but obviously this is a problem and you always need to weigh this up in your individual patients. So what about treatment? So we started Patricia on some ACE inhibitors, angiotensin receptor antagonists. We can treat the edema with diuretics or a low sodium diet. We can treat her hypercholesterolemia with a statin, and we gave her some thromboprophylaxis because of her albumin of 17. So what about more specific treatment? Only about 10% of minimal change diseases will resolve spontaneously, and so most people are going to need treatment for them. So what does KDIGO say? Well, that tells us to give steroids, and patients with relative contraindications to steroids should have either oral cyclophosphamide or a CNI. What's the evidence for that? These are the only randomized controlled trials of prednisolone in minimal change disease, the biggest of which had the stunning number of 31 patients in it. So it's not based on much. Nonetheless, we know that it works, and it's the standard therapy for most people. And what I should have asked you is how long does it take to get into remission? Some of you are only going to give steroids for a couple of months. It takes longer than you think. If you look at this graph here, which is showing time to remission, 50% of the patients have only achieved remission at about 10 weeks. And a significant number of patients don't achieve remission until 4 or even 6 months. Yeah. So you often need to give the steroids for a prolonged period of time. And there's actually evidence that even if you do respond, you should still have a 6-month course, because if you stop before then, I mean, you can reduce the dose, there's a higher incidence of relapse. What about relapse? Again, this is a series from New York, and you can see here that actually at 6 months, 40% of patients had already relapsed, and 6 months isn't very long, is it? That's people who've gone into remission quickly and already relapsed, yeah? And similar data from China, again, 90% of patients went into remission, but with a relapse rate of about 50%, and that was at 6 months. This is data from Guy's Hospital, a bit more historic, but this was out to a year, and by a year, 75% of patients had relapsed. So you've had 6 months of high-dose steroids, and 75% of you relapse. It's not great, is it? So what about the alternatives? Well, what about calcineurin inhibitors? Why should they work? Well, we know that they have an effect on the immune system, and this is an autoimmune disorder, so if we switch off the immune system, then that should help. But they also work by stabilization of the actin cytoskeleton, and there was a fascinating paper 10 years ago now, which showed the way that cyclosporin actually goes and sits in the podocyte and helps keep that shape as you see it. And that's probably why they work sort of quicker than you would think they would work if they're only having this effect on the immune system. So what about cyclosporin as a first-line agent? You know, we are 30 years out from those trials of steroids, and there isn't a single trial cyclosporin as a first-line agent in all that time. There's one small case series which suggests that it perhaps works, but there was a mixed set of patients and they didn't tell you who was who in terms of who responded. But we know that it works for relapsing patients, yeah? With a 70 to 90% remission rate, but again, a high relapse rate on discontinuation of therapy. What about tacrolimus? Well, this is some data from the Hammersmith, which one of our registrars presented at the ASN this year. And you can see here that it's certainly effective. Of 50 patients, 22 out of the 50 had no relapses at all following starting tacrolimus out to 35 months, and the majority of patients had a significant reduction in their relapse rate. The problem is, again, is relapse. 11 patients stopped tacrolimus, 6 of the 11 remained relapse-free out to 26 months, but 5 of the 11 relapsed, and when they relapse, they tend to relapse quite early after stopping tacrolimus. So these patients often need a long time on tacrolimus, and we all worry about nephrotoxicity, but actually you can see here that if you're careful and you monitor these patients, and they need to be seen and their levels need to be monitored, then actually they do very well, because most of these patients with minimal change disease have normal renal function going into this. So what about tacrolimus in de novo minimal change? Well, there's one study, but they just couldn't quite bring themselves to get rid of the steroids. It's a very odd study. And they compared good numbers, 53 patients with standard treatment with prednisolone versus 56 patients where they gave IV methylprednisolone, 0.8 milligrams per kilogram IV for 10 days. I mean, how inconvenient is that compared to oral steroids? And then they switched them to TAC. And then they treated for 16 to 20 weeks and tapered the dose. And as you can see, there was no difference between the groups. The proteinuria fell at a similar rate, albumin rose at a similar rate. The relapse rates were similar between the groups, but what was hugely different was the adverse events. And you can see here in the steroid group a huge number of adverse events compared to the tacrolimus group, even though they were having 10 days of methylprednisolone to start with. So this is a series from one of our registrars some years ago now at the Hammersmith called Chris Lawrence, where he just looked at a series of patients who'd been treated for minimal change disease. 24 of the 30 patients had standard treatment with steroids. 41 patients with minimal change, 30 received steroids, and 11 got tacrolimus. 24 of the 30 patients on steroids went into remission, and interestingly, the non-responders in the steroid group then responded to tacrolimus. In the tacrolimus group, 2 were switched in the first week because of probably we probably wouldn't switch them nowadays, I don't think, for either of those reasons, but we did at that time. But again, small numbers, but similar rates of remission on the tacrolimus. And interesting, the patient that didn't respond to tacrolimus then had steroids added and responded to the steroids. So you can go from one to the other. If one doesn't work, you can switch to the other and vice versa. And this formed the basis of the MINTAC trial, which is a multi-centre trial run via the Renal Association. And as you can see here, we've randomised patients to see either prednisolone or tacrolimus alone, and we're looking at remission and relapse rates. And we've just finished recruiting to that last month, and so hopefully we'll be able to bring you some results from that in the next year or so. So what about cyclophosphamide? So oral cyclophosphamide likewise works. It's only been tested in steroid-dependent or relapsing patients. You need to give 12 weeks oral cyclophosphamide. Remission rates are good and with less relapse than CNIs, but obviously a different toxicity profile. This is another series from China. They seem to have a lot of minimal change disease in China, and a lot of our studies actually come from there. This was looking at 14 patients given 6 months of cyclophosphamide and steroids versus 12 patients treated with tacrolimus and steroids. And you can see the remission rates here are similar, and perhaps slightly less relapse in the cyclophosphamide group. There are other drugs that we can use for steroid avoidance, mycophenolate, levamisole, azathioprine. And the bottom line is that most of these second-line agents work. This, again, is a series from New York. It's a rather complex slide, but what you can see is the remission rates here, 55% overall for cyclophosphamide, 61% cyclosporin, 75% tacrolimus, 64% responded from mycophenolate, giving an overall rate of about 61%. And what's not surprising is that those who were treated because of steroid dependence respond better than those patients who are treated because they're steroid resistant. And I'll come back to that again a little bit later. So what about our new favourite drug of the moment, rituximab? So this has been used extensively in children and less so in adults. Again, we've got no randomised controlled trials, but there's very good evidence now for its effectiveness in adults. This was a study from the Royal Free, where they looked at 15 patients with frequently relapsing or steroid-dependent minimal change. And the mean steroid-free survival after rituximab was 25 months, which is excellent in these patients because they were all relapsing frequently prior to going into this, with a decrease in frequency from 2.9 relapses per year to 0.4. This is our series of patients from the Hammersmith, which shows similar results, really. 19 patients followed out to nearly 3 years. 8 patients were nephrotic at the time that they were treated with the rituximab, and 6 of the 8 achieved remission or partial remission on rituximab. And of the 17 of 19 patients then who were in remission post-rituximab, 9 had no further relapses. 3 of those 9 were treated with top-up rituximab. As you know, we don't really know what to do at the moment because there are no proper studies. And of the 8 patients who relapsed, 6 of the 7 went into remission with another course of rituximab. And the only thing that we could really say from this was that, unsurprisingly, once your B cells start to reconstitute, then that's a predictor of relapse. So what's the problem with all these treatments? Well, the problem is the toxicity. And, you know, it really never fails to amaze me that we are still so wedded to steroids. After so many years, we still haven't managed to get any proper trials as an alternative. You know, steroids really do trash patients, weight gain, diabetes, GI ulceration. And remember that these patients are often getting 6 months of steroids, high dose, often for 2 or 3 months prior to going into remission. And then with a 75% relapse rate, often they're going to need repeated courses. How does that weigh up against other things? Well, tacrolimus, commonest symptoms probably are tremor and cramps. Those are usually dose-related and resolve when you reduce the dose a bit. It's an immunosuppressant, so there's an increased risk of infection and cancers in the long term. But what everyone gets very, very worried about is nephrotoxicity. And what we really need to be clear about here is the difference between the acute rise in creatinine that you see when you put people on a CNI compared to the chronic toxicity. And the only one that matters is this. So when you put anybody on tacrolimus, it's like an ACE inhibitor or an angiotensin receptor blocker. It has a hemodynamic effect on your kidney, and your creatinine will go up, or your GFR will fall 10 to 15%. And that doesn't matter, as long as it doesn't continue to rise. And that's why you need to watch these patients very carefully, particularly when you start them. And you'll find when you take them off the drug that the creatinine returns to normal. So what we worry about, though, is this, chronic CNI toxicity, where you get scarring in the kidneys. This is irreversible. You get hyalinosis, tubular atrophy, and interstitial fibrosis. And this is particularly a problem in patients with FSGS, patients whose CKD is progressing anyway due to their underlying disease, and often, even with renal biopsies, it's very difficult to tell whether their increase in scarring is due to the underlying disease or due to the CNI. Cyclophosphamide, again, as we've said, it's effective, but does cause severe marrow suppressions, and infections are a problem in these patients. They should all have Septrin prophylaxis. Infertility, often this is a disease of young women. Actually, a course of 12-week cyclophosphamide in your early 20s has very little effect on your fertility. The worry is when you get into your 30s and your fertility is already starting to decline, and that's when it becomes much more of a problem. Rituximab, amazingly well tolerated considering what it does to your immune system, but there is an increased risk of infections, and these patients often need multiple doses, and we really don't know, I don't think yet, what happens when you're on your 8th or 9th course of rituximab. So I think, you know, we just need to keep a little bit of an open mind as yet as to what this does to people further on down the line. So let's go back to Patricia and see what we did with her. So we decided she did need treating, and we went with standard therapy of prednisolone. We gave her some Clexane prophylaxis, some lansoprazole, some Atcal D3, and some frutamide for her edema. And how did she do? Well, 6 weeks after starting treatment, she went off to Poland, and she came back from Poland a bit short of breath, went to A&E, and was given some augmentin for a chest infection. And then we saw her in the clinic a couple of days later. Albumin hadn't really shifted, only had 6 weeks of steroids at this point, so we weren't too worried about that. But she was still a bit short of breath. And actually, on closer questioning, it turned out that she'd driven to Poland with her boyfriend in the car. The car was a bit full, so she hadn't taken her Clexane and her Sharps boxes with her because they didn't fit in very well. And this was her CTPA. And you can see here she's got a massive pulmonary embolus there, almost taking out the whole of the right pulmonary artery. So that wasn't very good. We warfarinized her, and we carried on with the high-dose steroids. And about 4 months in, we were now in mid-May, and really she'd not done very much. Her albumin had crept up from 19 to 22. She was looking horribly cushingoid, and we really felt that at this point we were going to need to change things because this wasn't working. She didn't want cyclophosphamide because of the fertility concerns, and so we switched her on to tacrolimus. And as you can see, we started the tacrolimus about here, and steadily she went into remission and achieved a complete remission about sort of 4 or 5 months later. So that was all very well, except that it wasn't over then, because she came back in November 2015. Her nephrotic syndrome remained in remission on tacrolimus monotherapy. X-ray of her hip didn't show very much, but we're talking about steroids, so it won't fail you to note that this is what her MRI showed, and with a normal X-ray. So extensive avascular necrosis of the hip, actually mainly on the right, but also a bit on the left as well. And this is in a 21-year-old lady. So successful treatment of her minimal change disease, but significant morbidity, both due to the nephrotic syndrome itself and the side effects of the treatment, which didn't even work for her. So I'm going to move on to FSGS now for the second half of the talk. As I say, we consider this part of the same disease, really, the same disease spectrum as minimal change disease. There's an abnormality of your immune system producing some sort of circulating factor. And really, you know, I think we should stop calling it FSGS. I don't know what the other consultants in the audience feel. I mean, this is a circulating factor-induced podocytopathy with scarring, isn't it? FSGS is just the scar, yeah? And then perhaps we would learn to start differentiating properly between primary and secondary FSGS, which is the problem with most of the studies here, that a lot of those studies are not careful about who they put in, and they're treating a lot of people who've just got scarred kidneys due to another disease, okay? So if you want to go to sleep now, this is the crux of the next half of the talk. We use the same drugs as minimal change because it's a similar disease. We've got less evidence and there are worse outcomes. And the most important thing, and I know I keep coming back to this, is to identify whether this really is primary or idiopathic FSGS. And these are some of the causes of secondary FSGS. So we've got a whole host of genetic ones, and there's more than that now. There seems to be a new one every few months. It can be associated with viruses, with drugs, and anything that causes glomerular hypertension. So anything that reduces your renal mass, be it renal dystrophy, reflux nephropathy, or anything where you have an initial normal renal mass, but you've got interglomerular hypertension, and the particular one here, obviously, is obesity. So how do we differentiate between the two? Well, the answer is actually often it's very difficult. People with secondary FSGS tend to have lower levels of proteinuria, and they don't usually present with severe clinical nephrotic syndrome. There's a typical picture on histology. They tend to have a perihilar pattern and some glomeruli, usually with glomerulomegaly, reflecting what else is going on in the kidney. There's less foot process effacement, and the most important thing about these patients is that they do better and they don't respond to immunosuppression. So we need to protect these patients from having unnecessary toxic drugs that aren't going to improve their outcome. Just to go back a little bit, I think it's worth just saying a word here about African Americans. As I said at the beginning, your underlying lesion depends on your race. And the difference between blacks and whites is most marked in FSGS. And this is because there are two polymorphisms in the ApoA1 gene, which are associated with FSGS, which are only present in African Americans. They're not present in European, Japanese, or Chinese populations. And that's probably because this gene variant gives some protection against trypanosomiasis, and that's probably why it's so prevalent in those populations. So, clinical predictors of outcome in FSGS, well, it won't surprise you to know that you do worse if you've got heavy proteinuria, or you start with a scarred kidney and a reduced GFR. You do worse if you're of black race. In terms of pathology, tip lesions tend to be more benign and tend to respond better to immunosuppression, whereas collapsing FSGS tends to be more resistant. And the most important thing to know in terms of what we can influence as nephrologists is that if you can get remission of the proteinuria, they do better. So it doesn't really matter how you do it, but you need to get these patients into remission if you can. And this is just a series sort of showing exactly that fact, that basically if you don't go into remission, you only have a 40% chance of renal survival out at 10 years. If you get full remission, you get a 90% chance of renal survival at 10 years, but even a partial remission is worth going for because, look, that increases your renal survival from 40 to 78%, so a significant difference. So let's go on to a patient. So this is Veronica, 29-year-old lady, presented with nephrotic syndrome back in 2009. Severely nephrotic, very suggestive of primary, with an albumin of 11. She actually presented with a swollen arm due to an axillary vein thrombosis. Normal serum creatinine, and a biopsy showed FSGS, and this looked very like idiopathic or primary FSGS. So how would you treat her, and how long for? So treatment, steroids. Okay, CNI, tacrolimus, cyclosporin. Few for that here, okay. Cyclophosphamide, she's heading into her 30s, probably not so good. Rituximab, no, okay. And how long for? 3 months? 6 months? 12 months? 5 years? Wait and see. So, standard KDIGO guidelines, again, similar to minimal change, high-dose steroids, and if there's relative contraindications, consider a CNI. No randomized trials in this, just some retrospective studies, the biggest of which is probably from Catran, as they've got a very good GN registry in Canada. And basically he showed that if you treat with steroids compared to controls, then you get less end-stage renal failure. And this is a sort of combination of a number of other studies showing the response to steroid treatment in adult FSGS. And you just need to bear in mind, as I say, that a lot of these patients may have secondary FSGS, so that it may be better than you think if you pick your patients carefully. But overall, complete remission in 45% of patients. Another 10% achieved a partial remission, which we know is helpful, and 45% didn't respond. So there are no studies of cyclosporin in FSGS as initial therapy. There's one small series from Neil Duncan of 6 patients with heavy proteinuria. All went into remission with tacrolimus. 2 had an initial decrease in GFR, but this subsequently stabilized. Relapsing, again, we know that it's effective, but we have high rates of relapse. This was a study from the North American Nephrotic Study Group, and they gave, this is just 6 months cyclosporin. And so you can see here versus controls that at 6 months, excellent remission rates of around 70%. They then stop treatment, but even with stopping treatment, you still have significantly more people in remission, but clearly a high rate of relapse, because the patients that have gone from here to here have clearly relapsed. And so often these patients, again, need prolonged courses of CNIs and very careful monitoring. Cyclophosphamide, effective, But it only seems to work really in patients who've had some sort of response to steroids. And maybe that's telling us that these patients have an autoimmune, i.e. they have a primary FSGS, and I'd be slightly reluctant to use that in someone who'd shown absolutely no response to other immunosuppression. MMF, again, this is a small study comparing 17 patients with MF versus 16 with prednisolone, and you can see here similar rates of remission and similar rates of relapse. So MMF can certainly be used as an alternative. This was a study of patients who are actually steroid resistant. This was from the NIH, and they used MMF with dexamethasone versus a CNI. And you can see here that they got probably comparable, slightly less than the CNI, but they did get some patients into remission with that. And what about rituximab? Again, less studies in FSGS, but there's a few series now. This one from Reganenti was in 30 patients, 10 children, 20 adults with either steroid-dependent or frequency relapsing nephrotic syndrome, and rituximab reduced the total relapses from 88 in the year prior to rituximab to 22 during the year of follow-up after rituximab. This is our series from the Hammersmith. We had 58 adults with minimal change or FSGS. Oh, sorry, this is the American series. I'm looking at the wrong one. So this was from Jerry Appel's group, which was presented at the ASN this year. So 58 adults treated with minimal change or FSGS or some other sort of podocytopathy. 62% gained complete or partial remission, and 32 of the 35 remained in complete or partial remission, and a lot of them got off a lot of the other drugs that they were on. The thing to note is of the drug-resistant patients, 11 did not respond to the rituximab either. So again, probably not effective in people who aren't responding to any other sort of immunotherapy. And then there's a few other things that we use. Abatacept was thought to be useful for post-transplant, but then probably proven not to be so, and plasma exchange. And if we've got a few minutes at the end, I'll just come back to post-transplant FSGS. So let's go back to our patient, Veronica. So what did we treat her with? Well, we gave her tacrolimus, so thought we'd have a different tac here. And you can see here that this is her serum albumin, so she responded very nicely. What do you think happened here? Relapse. Actually, this was a pregnancy. So she didn't become nephrotic, but she got pregnant. And this was her first pregnancy here, and then a second pregnancy here. And it's worth just saying this because you're often treating young women. And tacrolimus is a very useful drug in pregnancy. It's safe in pregnancy. You're likely to need to increase the dose, so you need to monitor your levels very carefully. And women taking tacrolimus can breastfeed because the ingestion in breast milk is negligible. So it's a very useful drug for young women of childbearing age. So she commenced tacrolimus in December 2009, and just when we were thinking about withdrawing it, she decided she wanted to try and get pregnant. So she had a pregnancy in 2012-13, and then that went well, so she wanted to carry on and get through a second pregnancy, which she did in 2014. So when I asked you how long you treat her for, and you all laughed when I said 5 years, we suddenly got to 2015, and she'd been on tacrolimus for 6 years in complete remission with 2 successful pregnancies. So we withdrew the tacrolimus. Guess what happened? Promptly relapsed. So this is her creatinine here. This is her first going on to tacrolimus. This is pregnancy number 1. This is pregnancy number 2. This is her coming off tacrolimus. Yeah, so this is the hemodynamic effect of tacrolimus. When you come off it, your creatinine comes down. But unfortunately, so did her albumin. And you can see here that her protein creatinine ratio went up. She promptly relapsed, and then we restarted the tacrolimus, and she's back now in remission. So how long do we treat her for now? Yeah, I don't know. She doesn't want to come off it. That's the other problem. You'll find that a lot of these patients become very resistant to coming off their immunosuppression because they feel so well, and being nephrotic is pretty unpleasant. So what about the safety then of tacrolimus in long-term FSGS? So this was a study from Tom Connor, who's now a consultant here, I think, isn't he? Yeah. So this was looking at 30 patients with primary FSGS who'd been on tacrolimus for at least 12 months, some for much longer than that. 19 of the 30 patients had a stable GFR and were fine with this, but you can see that about a third, 11 of the 30, showed a significant reduction from starting GFR. And the best predictor of that is your starting GFR. Yeah. So if you start with a GFR over 60, then you're likely to be fine. If you start with a reduced GFR, then maybe due to the disease, maybe due to toxicity from the CNI itself, you're much more likely to progress. Just a couple of slides, I think we've got a couple of minutes on post-transplantation FSGS. So following transplantation, 30% of patients with primary FSGS will develop recurrent disease. And the recurrent rate rises to 80 to 100% in second grafts in those who have recurrence in their first graft. So it's bad news if this happens to you. And post-transplant FSGS, unsurprisingly, is associated with inferior graft survival. So what are the risk factors? So childhood onset and rapid progression of initial disease make you much more likely. Race, possibly recipients of African American kidneys may be particularly high risk of recurrence. And there's lots of studies now going on measuring to genotype patients and donors to look at this in more detail. Clearly a history of recurrence in a prior graft. But a family history of FSGS generally predicts a low risk of recurrence because clearly these are patients with secondary FSGS who've got some sort of genetic abnormality rather than a systemic disease. It's really important to think about these patients and think about it and have a plan before you go into transplantation. Early diagnosis is really important. You need to monitor these patients for proteinuria. And if they have proteinuria, they need an early biopsy with electron microscopy. And normally in transplant patients, we're not taking samples for electron microscopy, are we? Because quite often the kidney will look normal on light microscopy, but you'll have extensive foot process effacement on your electron microscopy, which will give you your diagnosis. And these lesions are reversible if you treat them early. There are no controlled trials, but there is evidence in adults of effectiveness of both plasma exchange and rituximab. That the Hammersmith, we've implemented a regime in recent times of a combination of those two, and so far 9 out of 10 patients have gone into remission post-treatment, with 8 out of 10 patients being in remission at a year. So the important thing in this is to diagnose this early before they get irreversible scarring in their kidneys. So conclusions then. So as we've discussed, nephrotic syndrome is not benign. It's a medical emergency. These patients need to be seen and assessed because there's significant mortality and morbidity, both from thrombosis and AKI. Generalized treatments, ACE inhibitors, angiotensin receptor blockers, thrombotic prophylaxis, low-salt diet, statins. And then the treatment now, I really think we just need to start to be thinking about this a bit more carefully. We need to be tailoring our treatment to our individual patients to see what's the best from them and weighing up the benefits of the treatment versus the side effects. Steroids, they're effective, but their high doses are required and they have a very poor side effect profile. Tacrolimus, effective, no effect on fertility and is safe in pregnancy. Relapse rates, though, are probably higher than with other therapies, but toxicity generally lower. But these patients need to be monitored. And if there's any doubt about what's going on, then you need to rebiopsy them to exclude a CNI toxicity. Cyclophosphamide, effective, less relapse, but clearly problems with toxicity, bone marrow toxicity and fertility. And rituximab, again, increasing evidence in relapsing disease, well tolerated, but we really don't know how to give it yet and how often we have to give it, or really the side effects of repeated courses of rituximab over many years. So, tailor the treatment to the patient, long-term follow-up, and certainly all our UK trainees, if you're interested in glomerulonephritis, please do get involved. The Renal Association, as you know, has clinical groups for all sorts of disease areas now. There's transplantation, there's the glomerulonephritis clinical practice group. We meet sort of 2 or 3 times a year, and we're putting together trials so that we can actually start to get some proper evidence so that we can tell our patients realistically in the clinic so they can make a proper choice of what treatment they choose to have. We've recently just put in a proposal for the use of rituximab in minimal change in FSGS, and so do please get involved because we need every nephrologist in the country to be involved in this if we're going to recruit patients with these rare diseases to the trials. And that's just to thank some people who've been helping with this work. Okay.